Good morning. Thank you for joining us. Today we will be discussing our upcoming BRB study on incidences of coronary artery disease in the Philadelphia area. But first, let's all introduce ourselves. My name is Emily. I'm a senior research coordinator here at the University of Pennsylvania, and today I will be outlining our research plans.
Hello, my name is Johanne, and I am also a senior research coordinator at the University of Pennsylvania. I'm currently studying for a PhD in biomedical sciences, and today I will be discussing the anatomy and physiology of coronary artery disease.
Hi, I'm Emily. I'm a nurse practitioner at the Hospital of the University of Pennsylvania in the Department of Cardiology. I will be covering the pathophysiology of coronary artery disease.
Hi, my name is Taylor, and I'm a nurse practitioner at the Hospital of the University of Pennsylvania, Department of Cardiology, and I will also be discussing the anatomy and physiology of coronary artery disease.
We believe that assessing the incidences of coronary artery disease in Philadelphia will improve health outcomes and treatment plans for our patients. It is imperative to continue innovating our treatment practices as we assess our technology and try to expand it. That's why we need your help. You are all innovators in your respective fields of business, technology, and healthcare, and we want these fields to come together to create better treatments for coronary artery disease. So today we are going to explain to you what we already know about coronary artery disease, what it is, how it develops, and how we currently treat it. Then we will open the floor for questions.
Thanks, Emily. So, as I said before, I will be discussing the anatomy of coronary artery disease, but I'd like to begin with just some basic heart anatomy. The heart, in the simplest of terms, is a muscular organ that serves as a transport system pump for blood throughout the body. The heart is around the size of a fist, is hollow/cone shaped, and weighs less than 1 pound. The heart is located in the thoracic cavity of the body or the upper chest, posterior to or behind the sternum and in between the lungs. The heart has a broad, flat base that is directed toward the right shoulder and an apex directed toward the left hip.
The heart is enclosed in a double-layered sac that forms its most outer layer, the pericardium, which consists of both fibrous and serous layers. The fibrous layer of the pericardium, a dense tissue layer that protects the heart, anchors the heart to surrounding structures and prevents it from overfilling with blood. Below the fibrous layer is the serous layer of the pericardium. This is a thin, slippery, two-layered serous membrane that forms an enclosed sac around the heart. The parietal layer attaches to the large arteries exiting the heart, turns down, and continues to cover the external heart surface to become the visceral layer. In between the visceral layer and the parietal layer is a pericardial cavity, which contains pericardial fluid that allows the heart to be mobile and functioning in a friction-free environment.
Now that we have covered the outside layers of the heart, we will move on to discuss the layers of the heart wall. The heart wall includes the epicardium, myocardium, and the endocardium. The epicardium is the visceral layer of serous pericardium that we discussed before. The myocardium forms the bulk of the heart wall, and it is the layer that actually contracts to contribute to pumping blood throughout the body. The endocardium lines the heart chambers. The heart has 4 chambers, 2 upper chambers called atria and 2 lower chambers called ventricles. The interatrial septum and the interventricular septum are responsible for providing the structural divide of the chambers. The atria are the receiving chambers for blood to return to the heart from the blood vessels throughout the body. The atria are small and thin-walled because their function is to contract minimally to push blood down into the ventricles. Blood enters the right atrium via 3 veins: the superior vena cava, the inferior vena cava, and the coronary sinus.
The coronary sinus is a collection of smaller veins that merge together to form the sinus. The coronary sinus is a large vessel that collects blood from the myocardium. It delivers deoxygenated blood to the right atrium along with the superior vena cava. The veins that enter the left atrium transport blood from the lungs back to the heart and are called pulmonary veins. The 2 chambers that make up most of the volume of the heart are the ventricles. Ventricles are the discharging chambers in the actual pump of the heart. Their walls are thicker because of this. When the ventricles contract, they push blood out of the heart and into the circulation of the body. The right ventricle pumps blood into the pulmonary trunk, which is responsible for directing blood to the lungs. The left ventricle is responsible for pumping blood into the aorta. Blood is going to flow through the heart in one direction only, from the atria to the ventricles and out of the large arteries at the top of the heart. There are valves in the heart that form this one-way traffic of blood flow. The valves open and close in response to different blood pressures in the chambers. The two atrioventricular valves, AV valves, are located at each atrioventricular junction. The semilunar valves are located at the opening of the aorta and the opening of the pulmonary artery.
The heart is technically a double pump. Each side of the heart supplies its own circuit. The left side of the heart is the systemic circuit pump, and the right side of the heart is the pulmonary circuit pump. The pulmonary circuit carries oxygen-poor blood away from the heart to the lungs and then returns oxygen-rich blood back into the heart. It is served by the right ventricle and is a short, low-pressure circulation. The systemic circulation carries oxygen-rich blood away from the heart to the body tissues and then returns oxygen-poor blood back to the heart. It is associated with the left ventricle and encounters much more friction and resistance to blood flow than the pulmonary circulation.
Now we will explain the exact route of blood flow through the heart. Oxygen-poor blood returning from the body tissues enters the right atrium through the superior vena cava, inferior vena cava, and the coronary sinus. Once it arrives in the right atrium, the tricuspid AV valve will open, allowing blood to then flow into the right ventricle. The blood enters the right ventricle, the pulmonary semilunar valves open, and the blood flows into the pulmonary trunk. Blood enters the pulmonary trunk still as oxygen-poor blood. This blood is carried through two pulmonary arteries and into the lungs to receive oxygen. The now oxygen-rich blood returns back into the heart via the pulmonary veins and into the left atrium. Once the blood arrives in the left atrium, the mitral valve, AV valve, opens and the blood flows into the left ventricle. The blood will then leave the left ventricle when the aortic semilunar valve opens and enter the aorta.
Due to these circulations, the heart is continuously filled with various amounts of blood, but this blood provides only small amounts of nourishment to the actual tissues of the heart wall that we discussed before. Thus, the heart receives nourishment through the coronary circulation, which is defined as the functional blood supply of the heart and the shortest circulation in the body. The left and right coronary arteries arise from the base of the aorta and go on to encircle the heart in the coronary sulcus. The left coronary artery runs along the left side of the heart and then breaks off into two major branches, called the anterior interventricular artery and the circumflex artery. The right coronary artery runs along the right side of the heart and also divides into two major branches called the right marginal artery and the posterior interventricular artery. These coronary arteries provide a pulsating blood flow to the myocardium of the heart. They lie in the epicardium layer and have branches that extend inward to nourish the myocardium. The coronary arteries will deliver blood to the heart when it is relaxed. During contraction, when blood is being pumped through the heart, these arteries are ineffective as they are compressed by the contracting myocardium.
After blood passes through the capillary beds of the myocardium, venous blood is collected by the cardiac veins to form the coronary sinus. Remember, the coronary sinus is what empties blood into the right atrium. The great cardiac vein, the middle cardiac vein, and the small cardiac vein are the three main parts of the coronary sinus. To sum it up, coronary circulation is the circulation of blood in the coronary arteries of the heart's muscles.
The vessels that remove deoxygenated blood from the heart muscle are known as cardiac veins. The image projected gives an outline of exactly how blood will flow through the coronary circulation to nourish the heart wall. The heart muscle receives nutrients and oxygenated blood via the coronary arteries. Two main coronary arteries will branch off the aorta, and their branches are what go on to supply the heart muscle with blood. Thus, any type of disorder of the coronary arteries will present an issue for the overall wellness and functionality of our heart, the transport pump of the body. Keeping what my colleague said in mind, let's move on to see how the anatomy of the heart changes with coronary artery disease. From a young age, plaque can begin to cling to the walls of your arteries. Plaque is an accumulation of cholesterol, fatty substances, cellular waste products, calcium, and fibrin. As you get older, this plaque builds up, inflaming the arterial walls and increasing risks for heart attacks. Plaque buildup results from many things: smoking, high LDL or bad cholesterol, high blood pressure, high blood sugar, alcohol consumption, excess weight, and lack of exercise are all causes of plaque buildup in the arteries. The plaque tends to be sticky, so things traveling in your bloodstream, such as inflammatory cells, proteins, and calcium, can mix in with the plaque. With this increased volume, artery walls get pushed outward and the plaque grows into the lumen. This makes the lumen of the arteries narrower and restricts blood flow to your heart, which can then become depleted of oxygen and nutrients. Chest pain can evolve as a result of reduced blood flow to the heart. This is called angina pectoris, which can be triggered by stress-induced spasms of the coronary arteries or a temporary increase in physical activity which weakens the myocardial cells due to a lack of oxygen, but does not kill them. A narrowed coronary artery may develop new blood vessels that go around the blockage to get blood to the heart, but in some cases the plaque can rupture, forming a blood clot and blocking blood flow to the heart. This causes a heart attack. If a blood vessel to the brain is blocked, a stroke can occur. Next, we will be discussing the changes in blood flow that occur with someone with coronary artery disease. As we previously stated, plaque buildup on the walls of the arteries that supply blood to the heart causes the inside of the arteries to narrow over time. This impedes or completely blocks blood flow. This process, called atherosclerosis, results in blood flow not flowing as easy to the heart and brain, both crucial organs for normal. The inadequate blood supply to the heart is called coronary arteries ischemia. Myocardial infarctions, commonly called heart attack, result from prolonged prolonged coronary blockage and myocardial cell death. This differs from myocardial cell weakening, as in angina. Adult cardiac muscle is amyotonic, so dead myocardial tissue cells are replaced with non-contractile scar tissue. Non-contractile scar tissue reduces the heart's ability to contract normally and pump out the necessary quantity of blood with necessary quality of force. Depending on the extent and location of damage, myocardial infarctions can result in death. Damage to the left ventricle, for example, is the most serious possible damage resulting from myocardial infarction, since the left ventricle is the systemic pump. Finally, we will discuss mortality and morbidity rates and comorbidities and risk factors of coronary artery disease. Coronary artery disease is the most common type of heart disease, killing 370,000 people per year. Heart disease as a general category is the leading cause of death for Blacks, Hispanics, and whites, while it's the second leading cause of death in American Indians or Alaska natives and Asian Pacific Islanders. Regarding CAD morbidity, a CDC report from 2014 informs us that 11.5% of U.S. adults, or 27.6 million adults, are affected by heart disease. Now we'll move on to comorbidities and risk factors. Comorbidities of coronary artery disease include depression, diabetes, hypertension, atherosclerosis, and renal failure. Risk factors of coronary artery disease include high blood cholesterol, high blood pressure, prediabetes and diabetes, being overweight or obese, smoking, inadequate physical activity, stress, and an unhealthy diet. All these factors are ones that can be prevented and controlled through lifestyle changes and medication. Age, biological sex, and family history are 3 risk factors which cannot be controlled. The number and severity of risk factors one has make it more or less likely that one will develop CAD. Additionally, smoking and diabetes put you at a greater risk of experiencing coronary artery disease and/or myocardial infarction than any other risk factors. My colleagues have just given you a lot of information. Some of you may already know about heart anatomy and coronary artery disease, but it is important to discuss all of these factors before we discuss the significance of this information in pursuing our research of incidences of coronary artery disease in Philadelphia. Before we can tackle this problem, we must know the science behind it. Coronary artery disease is the most common heart disease in America. Here is a map of heart disease prevalence across the United States. Heart disease is more prevalent in the South than the rest of the country. The West and East Coasts have relatively few incidences of coronary artery disease. Let's examine Pennsylvania specifically. Here we have incidences of coronary artery disease by county. Philadelphia has abnormally high incidences of coronary artery disease compared with other counties in Pennsylvania. However, Philadelphia has a wealth of medical services. Collaborating with you all could lead to new innovations in coronary artery disease treatment, which we could share with the rest of the country and the world. Now that you know the basics and the goal of our research, let's open the floor to questions. Hi, great presentation. Why is plaque buildup so crucial to coronary artery disease?
Great question. So, plaque buildup inflames the walls of the arteries. This inflammation can impede blood flow. This reduction in blood flow can lead to the death of heart muscle, also known as a heart attack. This can also occur if plaque breaks off the artery wall and creates a blockage in the artery. Plaque buildup is the cornerstone of coronary artery disease and is incredibly harmful.
Hey, how you doing? My uncle's really overweight, so should he be worried about developing coronary artery disease? Action.
Yes, obesity is a comorbidity of coronary artery disease. Studies have shown that obesity is directly related to the disease. As body mass index increases, so does incidences of CAD. Fat distribution is also key in predicting CAD problems. If your uncle is overweight, he should make some lifestyle changes such as reducing alcohol intake, quitting smoking, and eating healthy foods. Losing weight can reduce the likelihood of coronary artery disease.
Any more questions? No? Okay, great. Thank you so much for coming to our presentation. You'll be hearing from us very soon about joining our research.